Welcome, everyone. I think that's my cue to get started. So first of all, welcome to this exciting lecture today, our webinar Q&A discussion on what changes Monday morning. Today, we're going to be talking about some really interesting trials that were discussed at ASCO this year. I'm going to start off by just letting everyone do a quick introduction. I'm going to let everyone introduce themselves. And also, just for the sake of this particular webinar today, since we're all colleagues, we discussed ahead of time, and we are all okay with calling each other by first name. So for the purposes of this conversation today, we'll be talking to each other utilizing first names. So I'll start with a brief info. My name is Dr. Shikha Jain. I'm a GI medical oncologist at the University of Illinois in Chicago. And I will be the moderator today for today's excellent panel with some fantastic guest speakers today. So next, why don't we have Dr. Mike Gibson do a brief introduction on who he is.
Oh yeah, hey everyone from Nashville. Mike Gibson, as you heard. I'm a medical oncologist. I treat upper GI cancers and head and neck cancers, but for the purposes of this, I think Sam and I are going to be talking about upper GI mostly. Look forward to a discussion. Thank you.
So next, how about Dr. Sam Klempner? Sam, can you give us a little bit of an intro as to who you are?
Yeah, sure. Sam Klempner. I'm a GI medical oncologist at Mass General in Boston. And like Mike, I'm focused primarily in upper GI, gastric and esophageal cancers.
And last, but certainly not least, Dr. Louise Connell, could you please give us a brief intro as to who you are?
Yeah, so my name is Louise Connell. I'm a GI medical oncologist practicing at Memorial Sloan Kettering in New York. And you can probably all tell from my accent that I'm originally from Ireland. So nice to meet everybody and happy to take part in the discussion today. My practice is predominantly colorectal cancer, and I'll be focusing on those abstracts today.
Fantastic. So without further ado, because we have a lot of abstracts to get through today, we're going to jump right in and we're going to start with colorectal cancer. So the first abstract we're going to be discussing is abstract 3500. And I'm going to give a brief overview of each abstract before we start discussing. So abstract 3500 was the final overall survival data for the phase 3 KN-177 study, or the Keynote 177. And it looked at pembrolizumab versus chemo in microsatellite instability or mismatch repair deficient metastatic colorectal cancer. So we know with Keynote 177, previous data had shown a superior progression-free survival for patients who are MSI high or deficient in the MMR with metastatic colorectal cancer. So this particular study that was presented at ASCO this year was looking at the final analysis of the overall survival data. There were 307 patients that were enrolled in this study, and they looked at pembro versus chemo plus or minus bev or cetuximab. And the chemo was at the dealer's choice for the oncologist who was treating the patient. One thing that's really important to note in this study is that patients were allowed to cross over to pembro. And so the primary endpoints were overall survival or progression-free survival. Secondary endpoints were ORR, DOR, and safety profiles, so looking at quality of life and side effects. The results of this study, so they found that this I think is very interesting, and we can talk a little bit about it. 56 patients actually crossed over from the chemo to the immunotherapy arm, to the pembrolizumab arm, and 37 more patients actually received a PD-1 or PD-L1 therapy off of study. The hazard ratio for overall survival favored pembrolizumab versus chemotherapy, and there was a trend towards a reduction in risk of death. The median progression-free survival was 16.5 months for the pembrolizumab arm versus 8.2 months for the chemo arm. And the overall risk reduction was 45.1% versus 33%. So this study concluded that pembro did have a statistically significant superior progression-free survival with fewer side effects, with a trend towards a reduced mortality. And so this study confirmed that pembro can indeed be effectively used for first line for patients with MSI high or MMR deficient metastatic colorectal cancer. Now, there's a lot to unpack there, and there's a lot of reasons why the discussion occurred as to why they didn't see a statistically significant difference in the overall survival when comparing the pembrolizumab arm versus the chemotherapy arm. So with that, I'm going to kick off the discussion, and I'm going to pass it over to Dr. Louise Connell. Louise, can you tell us a little bit about why you think this study might have had overall survival that didn't meet the statistical significant p-value, and what you can interpret and change in your practice after looking at the results of this study?
Right. So, I mean, I think you've done a very nice introduction overall in terms of the study. And, you know, I think it brings into focus a major question that comes up always when we meet patients in clinic. There's a lot of buzz around immunotherapy, and in colorectal cancer in general for many, many years, we've either had FOLFOX or FOLFIRI, which are used interchangeably in the first line. And the question is, you know, how we can personalize treatment more for these patients, right? And we're learning more about the molecular landscape. We know that in patients with MSI high or MMR deficient tumors, you know, we've seen data in later lines in terms of immunotherapy. So this study had a co-primary endpoint of PFS and OS, and they really only had to meet one of those criteria for it to be a positive study. So it is a positive study, despite the fact that the overall survival difference was not noted. I think, you know, from the discussions that I've seen around the study, some of the reasons that we didn't see a significant difference in terms of the overall survival was the fact that they had like a pre-specified criteria of a p-value that wasn't met. It was like 0.0246. So they still had a significant p-value, but it didn't quite meet that criteria. And also you mentioned the number of patients who crossed over. So on protocol, it was around 36% of patients who crossed over, and an additional 24% of patients crossed over to immunotherapy off protocol. So there was effectively a 60% crossover rate, which definitely could have skewed the data. I think, you know, despite all of this, you know, what we did see was that this is definitely a standard of care in terms of first-line treatment for patients with MMR deficient tumors. And also, I think what this highlighted was that in all patients, we should be routinely testing for MSI status when we meet them in the clinic to begin with. So, you know, the other important things that always come up, right, particularly when we're saying what's going to change Monday morning, right? So Pembro every 3 weeks versus coming in, you know, it's a 30-minute infusion versus coming in every 2 weeks, being attached to 5-FU for 2 days, you know, so quality of life for patients, you know, is better. The toxicity profile is different, but generally better. So I think while we didn't get that holy grail of a significant overall survival difference, there's many things that are telling us that this is the right maneuver in the first line setting for this subgroup of patients. And I think a lot of the difference in terms of why we didn't see significance was that tight pre-specified criteria that was there, and also the high crossover rate.
Yeah, I tend to agree with you. I think that crossover and the fact that also, as you mentioned, that so many people ended up getting PD-1 and PD-L1 therapy off of trial is really impressive. It's an impressive number of people who crossed over. And so it makes sense that we didn't achieve that holy grail, as you said, of the p-value. Mike and Sam, do you have anything to add to that?
No, I just understand that it's not this only trial that can be confounded by crossover. So it's unfortunate the way that worked out. But if I think I was listening correctly, although I haven't read the abstract, you still met an endpoint which allows you to have toxicity, either equivalency or less with the drug that was studied.
Yes, that is correct. So the toxicity profile with the immunotherapy as compared to the chemotherapy was definitely improved. So I agree, it does definitely meet that endpoint as well.
I would say that's a win for the patients. I think Louise mentioned that as she was discussing 5-FU pumps and all kinds of stuff like that. So that's great.
Yeah, I agree. It's overall definitely a win for a patient, but it's still a reminder to me that there's more to be done. You know, there is a fair amount of drop off early on, even on chemotherapy. And so I think that I'd be interested certainly to hear Louise's opinion about, where to go next. Because, people will ask about combo chemo IO for this. Can you improve upon that? And I think, there's still a lot to learn about MSI in general, but overall, definite win, definitely what I would do with the new MSI patient who came into my clinic.
Right, and to that focus, I mean, where do we go next? So one criticism that came up in the discussion was, a 60% crossover rate is very high, but what about the 40% of patients on the chemo arm who didn't end up getting immunotherapy? And it's hard when you're facing a patient in clinic who has the profile that technically fits for immunotherapy, and you're not giving them immunotherapy. So, you know, it's interesting to see why that happened and to delve a little bit more into that. In terms of where we go to next, I mean, I think it's a classical situation where we begin with these newer treatments and later lines, we move them forward to first line treatment and then trying to see where they fit in terms of neoadjuvant or adjuvant. The bulk of my practice, I'll be honest with you, is colorectal liver metastasis. You know, a lot of my practice focuses on either patients who have unresectable disease or trying to convert them to disease or to resectable disease. And I think, you know, one place of this we're trying to incorporate is how we involve immunotherapy in that. And pembrolizumab is a very attractive option for patients. I can only talk a lot as well during the last year with the COVID pandemic, trying to talk to patients who are uncomfortable with self-disconnecting from a 5FU pump, having to come back in again, you know, 2 days later in the months that were involved. A lot of the trend of what we did here actually really when things were very bad was moving people over to capecitabine, you know, so Capox or Capiri instead of Folfox or Folfuri. And that's not an easy drug in terms of quality of life for patients to be on. So I think this is definitely an attractive option. I think that, you know, this is something that I am doing and will continue to do if I have a patient whose MSI high is offering them Pembro up front.
Is it fair to say that considering the crossover rate of, I think you said 60%, that patients are very wise?
Yeah, I mean, people come in actively looking for this. And I'll be honest with you, even, you know, since I began practicing in the US before these studies were coming out, right? People were hearing about immunotherapy and in melanoma, in lung cancer. It's the buzz, right? It's where the commercials are. It's what people are hearing. I had a lot of discussions trying to explain why they didn't fit the right mode for that. And now we're learning more and we're finding that these are the right people. And I think in patients even who don't fit that criteria, a lot of our clinical trials in microsatellite stable patients, we're trying to incorporate immunotherapy with other agents to boost a response, right? To see that, because these are the drugs that patients want, in my experience. They're asking for them.
Yeah, and I know that, you know, talking about when Sam was asking kind of next steps, I think in the adjuvant setting, there's a lot of discussion as to whether we can start potentially considering IO therapy in the adjuvant setting for these MSI high patients. And I'm hopeful that in the next couple of years, we'll start seeing some data that can help that shift as well, because as of now, there is no indication for IO therapy in the adjuvant setting for these MSI high patients, but it could potentially be something that we see down the pipeline in the future. Do you think, Louise, do you think that's where this is potentially heading in the future? Do you think that's something that we might see at ASCO 2023 or 2024?
I think definitely. I mean, I think, as I said, it fits what typically tends to happen, right? You see benefit in later lines of metastatic, it moves forward, and then you get to adjuvant. There are trials ongoing where, even though it's not approved, you know, in patients who have positive cell-free DNA, perhaps, then we're using it, and we're still learning a lot about it. But I think it's an attractive option. I think it's something we're going to be hearing more about. And I think we're going to be learning more about who are the right patients to select. Or even how to boost responses, as I said, in patients who aren't the classical fit for this, you know? Yeah.
So to answer the question of the panel, what changes Monday morning? How about I don't know if we want to do a little emoji or just a raise of hand. Do you think this is going to change your, I mean, you're probably already doing this, but if you're practicing and if you're treating patients with MSI high colorectal cancer, how many of us would feel comfortable starting first line with immunotherapy?
Yes, for me.
If I was, the answer is yes.
So that's a unanimous.
Sam says yes, I say yes too.
So that's a unanimous yes. So I think that, I don't think it necessarily changes Monday morning. I think it's just continuing, but it proves the point that what we're doing now is probably the most effective strategy for these patients and probably gives them a better quality of life as well as better outcomes overall. All right, moving on to the next exciting colorectal study. So this is abstract 3504, results from the randomized FOCUS-4N trial. So this trial looked at oral maintenance capecitabine versus active monitoring for patients with metastatic colorectal cancer who were stable or responding after 16 weeks of first-line treatment. So they basically were looking to see if there was any support to whether treatment breaks were supported in patients who are getting maintenance therapy with metastatic colorectal cancer. So in this Focus 4 trial, they randomized patients 1-to-1, and the primary outcome was progression-free survival, and the secondary outcome was overall survival and quality of life. There were 254 patients that were randomized in this trial, and they found that there was no difference in quality, no significant difference in quality of life, but there was a prolongation of progression-free survival with maintenance therapy, no overall survival difference. And so when treatment breaks were done. So basically this study is showing that there is no real obvious overall survival benefit to keeping patients on capecitabine for the long term. So it's that they concluded that putting patients on treatment breaks who have metastatic colorectal cancer who are getting capecitabine maintenance may be the right way to go. So
May I ask, so the randomization was after they had stable disease for some amount of time, they got randomized to observation or a holiday versus maintenance capecitabine?
Correct.
Okay.
Yeah.
Exactly. So Louise, what do you think about this study? What do you think about the design, and what do you think about this data that came out from this particular trial?
So before I get into the abstract, I'm just going to say I'm completely biased in that I do not like using maintenance chemotherapy in my patients. And I have a very honest discussion with them in that I always say to them, I think there's two camps of oncologists. There's people who do it, and there's people who don't. And I probably could count on one hand the amount of times that I've ever given maintenance therapy, because I think these patients do need breaks from treatment. And I know that this abstract didn't show a difference in quality of life, but I think in practice, you do see that they benefit from time off chemo. Having said that, I think, so I went into this looking at this extremely biased, and I do think it was a very interesting study. So the study, was an excellent study from the group in the UK where basically patients got the 16 weeks of induction chemo. They incorporated biomarker analysis, molecular testing in patients. If they had any mutations like PIK3CA, they were randomized into different arms. So these were patients who basically didn't have any obvious mutation, and then they were assigned 1-to-1 to capecitabine versus active surveillance. There's a lot of stress on the fact that they met the primary endpoint of PFS, but if you, again, it's, statistics, what is a significant p-value? It's a difference of, 2 months versus 4 months. The questions that come up are, right, we've got previous trials like Cairo 3, where you're looking at capecitabine and bevacizumab. And I think if that's your maintenance treatment, and again, you're bringing patients into a chemo unit to give them intravenous bevacizumab, time in the hospital coming, this trial is attractive because then it is Xeloda that they're taking at home, right? So it's more cost effective. They have time away from the hospital. But again, I think in practice, Xeloda is not without toxicity. And I think, I'm not sure if it's a geographical thing where I'm practicing right now, but I definitely see a lot of side effects with Xeloda here prior to the patients that I would have treated in Ireland. And again, the fact that this is a UK-based study, they said a lot of it was grade 1-2 diarrhea, hand-foot syndrome. I found that in my practice in Ireland, Irish patients could tolerate Xeloda much better than the patients that I treat here in the US, which could be specific to New York. But having said that, that's what I've seen. So I think, the question is, I come from a camp where less is more, and I think I prefer not to use maintenance in patients. I think they need time off chemotherapy. Some of the argument from the study was you're doubling the time that they're off full dose treatment, but then the question is, how well do they tolerate it when they go back on it, right? Because they haven't had any time off. So I think it was a very well structured study. I think it raises a lot of positive aspects in terms of maintenance. I think using Xeloda alone compared to previous studies of maintenance where it was Xeloda and Avastin is definitely more attractive. But I wouldn't change my practice based on this study, and I wouldn't be speaking to patients this week or next week about maintenance capecitabine based on this.
So I can say I agree with you on the maintenance in general. I do have some patients who I've had on other forms of maintenance therapy for a variety of reasons, but I think that this particular study, the way that it's going to change my practice, so to speak, is it's not necessarily going to change what I do. It's more going to change the way I talk about it with patients, because I think now if we have data that shows that giving patients those breaks actually doesn't have any major detrimental issues, I think that would be a really good indication for why we don't necessarily need to keep them on maintenance. Because again, as you said, anecdotally, I do tend to see a lot more side effects in patients who are on therapy. And not only that, the mental load of just being on therapy. I'd say a lot of my patients, when they get those treatment breaks, they feel better mentally because they don't feel like they're taking chemotherapy or they're not coming to see me as regularly. And so I think not only the physiologic side effects, but also the mental side effects are hugely impacted by the fact that you're not getting chemotherapy, 7 days a week or 5 days a week year round. So I agree with you. And I think that the way that it'll change my practice is really the way that I present the data to patients and say, there is data showing that if we give you treatment breaks or maintenance therapy breaks, or don't even give you maintenance at all, it's not going to necessarily affect how long you live. So maybe it does make sense, especially in my more anxious patients who there is that cohort of patients who want to be on treatment all the time because they feel like they have cancer and they're not doing anything about it. So I think it'll help frame the conversation a little bit better.
Yeah.
So there's actually a question, I think, that was put from our audience members. Is it not the 11th or 12th trial with maintenance therapy and metastatic colorectal cancer? All had the same results. MRC, COIN, Cairo, how many more do we need?
So that's a good question. I mean, and definitely even in the presentation, they referred back to these studies and they cross-compared, to Cairo and COIN. And I think the difference here is, or the argument from the group is that it's capecitabine and you're not coming in for your Avastin. But I mean, I think, definitely if you delve further into the presentation, they're looking at, how can you better select that proportion of patients that should be offered maintenance. And there was a hint that there was possibly some trends about primary tumor location and patients who had a PIK3CA wild type tumor. And there wasn't a lot of discussion around it. I think we're going to hear more from this study, but I think again, it's always a discussion with the patient, right? So you have those patients who are super fit, they're on full dose chemo. And as you said, they're not comfortable coming off treatment when they know that they still have disease present, right? And they just want to be on something. But I think that's a very small group of patients. The majority of patients that we see, as you said, they need time off. They need it physically, they need it in terms of recovery of counts, and they also do need it mentally. And I think what are we treating? And what I say to people is, you're treating the scan, but you're also treating the person, right? And if you're spending most of your time, coming in and out to see me or needing follow-up, or, you're not able to do things with your family because you have nausea or skin toxicity or things like that from capecitabine, then am I really helping you? And I do argue, I think there is a quality of life difference personally from personal experience in having time off treatment.
Yeah, and I will say, as I was reading the information from the trial, I had to do a double check, because every time I read that in this particular abstract, I am convinced that there's a typo or there's some sort of error, because I was surprised that they found that, but I 100% agree with you. Any other comments from our esteemed panelists? And if not, then we'll move on to the next abstract.
Well, I will defer obviously to Sam, but we face the same issue in esophagogastric cancer, but we're not blessed with as many trials. So back when I was just growing up, I was a chemo holiday guy. But the more I interact with my expert colleagues, more of them will continue the 5FU after they've stopped the FOLFOX, or in this case, I guess, Nivo 5FU. But I think we need a study. The current studies that they're designing in the ECOG and the NCTN is not plus or minus maintenance. It's different kinds of maintenance compared to each other. So I don't know if we're going to get excellent data like Louise described, but perhaps Sam remembers a little bit better.
Yeah, in my own practice, and again, I don't really see very much colorectal cancer. We do generally favor maintenance, but the disease biology is also different. We don't have the outcomes that our colleagues in colorectal cancer have, and progression is often quite quick and relatively symptomatic. So delaying that may have some benefit in terms of delaying the onset of significant symptom burden. But I agree, we don't have granular data to really speak to that. But we'll get to it when we talk about gastric and esophageal, but our tendency has been, you know, around 4 months of chemotherapy and then transition to maintenance 5-FU. Now maybe plus Nivo. But honestly, I was just impressed by the UK group and what they're able to execute with these trials. I mean, it's a massive undertaking and a nationalized, you know, system that's quite impressive, and certainly be jealous of doing this in the US.
Yeah, it seems if you have a national health service, you can really get some big studies done very quickly.
Yeah, it's fantastic. So actually, just one point that came up from that, you know, it'd be important to say I don't do just 4 months of induction chemo. I traditionally do 6 months. For example, if I've, you know, I typically use FOLFOX first line and keep FOLFIRI for second line, because again, I think quality of life on FOLFOX is better than FOLFIRI. So what I tend to do in the majority of patients is I'll do, you know, 4, possibly 5 months with oxaliplatin, but I'll often drop the oxali after cycle 8 or 10, and then they will finish out the 6 months with 5-FU. But once they've gotten to 6 months, I then stop. So I do have a longer induction than described in the study. And I never do less than 6 months in patients in terms of induction. I don't know, Shikha, what you do. You probably practice similarly, right?
Yeah, that's pretty much what I do as well. I do the 6 months, and then we talk about maintenance versus non-maintenance versus, you know, kind of holidays, so to speak. Do you, I'm curious, Louise, how often do you see these patients back? So after you finish your 6 months, if you're not doing maintenance therapy after that, how often are you seeing them? How often are you scanning them? What's your follow-up for those patients?
Right. So it's a very good question, actually. So in people who I know are, you know, CEAers, so I know that I have the CEA to follow. Basically, what I'll do is I'll check the CEA every 6 weeks off chemo, and then I'll scan them at 3 months. And then in patients who really the CEA is non-informative, I'll still draw the CEA, but I'll scan them initially once I stop the treatment every 8 weeks, so every 2 months. And then if I'm really seeing that, you know, everything is looking okay, I may extend to 3 months. But that's how I tend to follow them.
That's really interesting. Yeah, no, I think that sounds similar to what I do. And it's interesting because I do know a lot of people who just continue FOLFOX indefinitely until the neuropathy becomes so severe that patients can't tolerate it, or until the neutropenia or, you know, cytopenia has become bad. But I think that I think with all of these trials coming out showing that maintenance therapy isn't necessarily the way to go, I think the way you're describing with the 4 to 6 months, depending on where you practice and what your plan is after, of the more intensive therapy, and then after that, kind of surveilling and seeing when patients need to resume therapy. When patients progress, so this is another question that if somebody hasn't put it in the chat yet, I'm sure it'll come up. So 6 months of therapy, and then you do maintenance. Then when they start progressing again, you put them back on the original therapy that they were on, or do you transition to second line FOLFIRI, or does it depend on how long until they show that progression?
Yeah, it's a very good question. I mean, I would say to you, 95% of the time I put them on FOLFIRI. I mean, if they've had a really long time interval from FOLFOX, then I will consider putting them back on oxaliplatin. But my experience is, you know, when you go back to oxaliplatin, you know, without fail, they begin to run into issues. I have them on desensitization protocols. And again, it comes back to this. I mean, I think this is coming up a lot in our discussion. It comes up to quality of life, right? So sitting in a chemo unit from the morning to night to get oxaliplatin, if I haven't given them irinotecan yet. So I tend to lean much more towards FOLFIRI and keep oxaliplatin in reserve for the second recurrence, so to speak. And also, I think, you know, I work in a center, obviously, where, you know, we're very geared towards clinical trials, right? And it has to be the right fit for patients. But I think in a lot of our trials, patients need to have had exposure to FOLFOX and FOLFIRI to be eligible for studies, right? So if I go back to FOLFOX and, you know, they're beaten down from FOLFOX a second time around and they've never been exposed to irinotecan, I've lost an opportunity to possibly get them on a trial while they're still fit. So I think I can't even think of somebody that I've gone back to FOLFOX super quick with. It would have to be like a 2 or 3 year interval between, which is extremely rare in the patient population that I see. And as I said, I think even in those people where I put them back on oxaliplatin a second time around, despite the time interval between it, I find that the neuropathy comes back much quicker. There's a lot more issues in terms of the allergic reaction. Most of them are on a graded, if not on a desensitization protocol a few cycles in.
And then one last question before we move on to the next abstract. So in these patients who are also getting Bev or cetuximab or panitumumab, how do you incorporate those into their therapy plan when you give the 6 months and then you give the break after that?
So I typically don't use EGFR inhibitors up front. I come from a rationale that I think you always want to keep something in reserve. I'm also not a person who starts somebody off on FOLFOXIRI. I typically start on FOLFOX. If I'm getting a response, I keep them on it. If I need to escalate, then I will. But I think, you know, as we touched on in the discussion on immunotherapy, we have very limited good standard treatment options in colorectal. And if I'm getting a response on a regimen, you know, I want to keep these drugs for later on, as well as in terms of the toxicities the patients experience. So, you know, routinely in first line, FOLFOX is my standard. I may add in Avastin if appropriate, or I may escalate to FOLFOXIRI depending on the individual situation. I typically don't use cetuximab, and I reserve to use it in combination with FOLFIRI second line in those patients. But again, I think I have a disproportionate amount of KRAS mutated patients in my practice. So it's actually a rare gem if I have the option of being able to use one of the EGFR inhibitors. So, and again, you know, my patient population is very biased. I see a lot of these colorectal liver metastases. They've typically progressed on a lot of these treatments, and they're looking for something a little bit different. So, but I don't use EGFR inhibitor up front.
Great. So the question of the hour, what changes Monday morning? So I guess the question would be maintenance therapy versus not maintenance therapy. And I think I know what the answer is going to be for that, especially since Louise has told us so strongly what her opinions are on maintenance therapy. But so I guess the question is, how many of us would not be using maintenance therapy moving forward with colorectal cancer? And I will say, no, for the most part, I will not be. So I think that's pretty unanimous with Sam abstaining.
Yeah, honestly, maybe I'll see a handful a year, but I do find some of the tribe data compelling in terms of the like triplet and maintenance 5-FU-Bev and re-escalation. So I do think I probably do it a little bit more than all of you on the panel. But again, I don't really see this disease very much. So I'm biased by my practice in upper GI.
Excellent. So I think that was a really exciting discussion. Honestly, for years, I don't feel like there's been as much excitement over colorectal therapies and upper GI therapies. So I think it's really nice that we have these new options and these new discussions that are happening. And yes, while this is the 12th or 13th or 14th trial in this space, I do think that it is an important thing to continue to discuss. And I agree, the discussion about the UK and the NHS system, I think, would be a great discussion for another panel. So I think we should continue to look at these patients individually, as Louise had mentioned. I'm going to take a quick pause and just throw out there to anybody who is attending this current webinar, if you have questions, please feel free to share them, because we will try to get to the answers of as many questions as we can during this panel. So please feel free to throw your questions in the chat, and we're happy to answer them as we move forward. Okay, so the next abstract we're going to be talking about is abstract 3505, which is the DESTINY trial. Trastuzumab deruxtecan, or TDXD DS8201, in patients with HER2-expressing metastatic colorectal cancer. And these were final results from a phase 2 multicenter open label study. So a little background on this drug. So TDXD is an antibody drug conjugate of humanized anti-HER2 antibody bound to topoisomerase 1 inhibitors by cleavable linkers. So this was a primary analysis in a phase 2 study with HER2-expressing metastatic colorectal cancer, showing promising anti-tumor activity and a manageable safety profile. So the methodology for this particular study, patients with essentially confirmed HER2-expressing RAS wild-type metastatic colorectal cancer who had progressed after 2 or more regimens were found to be eligible. These patients received the TDXD every 3 weeks in 3 separate cohorts. And the endpoints they were looking at were overall response rate, and then secondary endpoints were disease control rate, progression-free survival, and overall survival. And this study concluded that there was promising activity and durability with a longer-term follow-up in these patients who received this particular drug. And the one thing that they noted that I thought was really important was ILD is one of the important risk factors that needs to be monitored. So obviously this may not be the best drug for your patients who have underlying lung disease. I think this was a really interesting trial, especially for HER2 metastatic colorectal cancer, which is something that I think is newer on the colorectal space when we're looking at studies. So Louise, I'd love to hear your thoughts on this particular trial and what you think it means for the way we treat these particular patients.
Right. So, I mean, I agree with you. I think this was a very interesting study. And I think, again, it looks at how we're trying to learn more about the molecular landscape in colorectal cancer and trying to optimize our use of molecularly directed agents. I mean, we've made a lot of ground in terms of, KRAS wild type tumors with BRAF mutant tumors, and HER2 is, has an unmet clinical need essentially, right? So it's a small proportion of patients, 2 to 3%, but we don't have any currently approved anti-HER2 therapies in this patient population. So I think this study, I'll be honest with you, it's an interesting study. I was a little bit underwhelmed with the results, but it's a very niche area, right? And I think there's a lot more to come from it. And I think it's hypothesis generating, it's interesting, but I don't think it's going to change my practice currently. So the way that it was designed, it was about an 86 patient study. They looked at patients who had HER2 positivity, and they divided it into 3 cohorts, and clearly patients who didn't have either HER2 3+ or HER2 2+ with ISH positive didn't really get the response rates. So even in the narrow group of patients with HER2 positivity, we eliminated a certain set of patients. So if you only had 1+ in terms of positivity on IHC or 2+, you really didn't benefit from the drug. So again, the numbers are getting smaller and smaller, and I think that's why some of this we still need to learn a little bit more about it. Interestingly, I think, from what we saw in the study was it didn't matter if patients had previously been exposed to other anti-HER2 therapies. So even in patients who previously had agents like trastuzumab, lapatinib, they still got responses on this study. It was more what was important was that degree of HER2 positivity that we saw. And I think in terms of the subgroups, that was the only factor that made a difference, as well as performance status, whereas prior anti-HER2 therapy didn't implicate. Again, having said that, it's a very niche group, it's a very narrow group. They narrowed it down even more. And these were patients who had already had 2 previous lines of therapy. So I think if you look at it in that context, they did well with what they achieved. But I don't think this is something that's ready for prime time yet, or is ready to, to change what we're doing day to day. I think the ILD is a very significant factor in this. It was in 8 of the 86 patients, and there were 3 deaths related to it. So I think there's more to learn in relation to that. And, as I said, I think it's opening up the space. We didn't have a lot of hope, I think, initially with BRAF mutated, and now a few years later, here we are. So I think this comes back again to one of your questions earlier in ASCO in 2, 3, 4 years time, will we learn more? I think we will, but I don't think on Monday morning I'm going to be trying to get a patient TDXD or enroll them in a study for this right now.
So Mike and Sam, I'm curious to hear your thoughts, because HER2 is obviously something that you see a lot more of in your practice. So I'm curious as to what you thought about what we just talked about. Do you think this is something interesting? Do you think it's promising, or do you think we're just making a big deal out of nothing?
I think it's encouraging to see a shared biology and some shared clinical activity. We certainly have a experience with this in upper GI, where the drug is actually approved based on a trial in the 3rd line setting. And we saw broadly similar trends in terms of ability to biomarker select patients. There may be greater benefit in the, more higher HER2 expressing, and probably even within the IHC3, the really truly high level amplifications may even do the best. saw some biomarker data from that trial. Response rate is about the same. It was a very similar, in the 40s kind of trend, which is in our population very encouraging for that group. But I totally share your concerns. I think clinically managing and monitoring for the interstitial lung disease is a real thing. It's a real toxicity. It's something that ranges from asymptomatic pickup on a CT scan while you're doing your restaging to, life-threatening complication. And that's going to be something that has to be factored in for this drug as it gets developed, both alone and in combination. And I don't see a lot of HER2 colorectal, but I think it's nice to have data for this target. Certainly other agents targeting the same target, which I've also shown activity. So I think it's going to get a busy space like it is getting a busy space for upper GI as well. But overall, my takeaway is this looks relatively consistent with the portfolio of TDXT activity in HER2 GI cancers. And the toxicity profile looks quite similar too.
I'm curious that they included, if I read this right, a 1+ IHC category here. I think there were three categories, and so when we know in upper GI that it's your 2+ HER positive or 3+ by IHC. So we've subgrouped it a little more to the advantage of the drug working. The second thing about Herceptin in our disease is it's frontline with chemo. So I don't know whether these are select patients that are going to be more difficult to treat given that they've already received 2 lines of therapy. And then curious, what else do you guys have in the colon world for these patients that aren't HER2 positive, since that's about 97.5% of the patients? Is that a space which is still begging for therapies as well?
Right, yeah. So I think, traditionally in terms of third line options in patients who've progressed on FOLFOX or FOLFIRI-based regimens is Lonsurf or Stivarga. And, the data is underwhelming to say the least. I think when we move on to the next abstract, it focuses a little bit on Lonsurf. And I think we're seeing a little more response when it's in third line when you add Avastin in. But again, I think in practice toxicity for these patients is high. So again, in my practice, what I tend to do, if I don't have, an obvious molecular driver to target, or if I don't have a clinical trial option, is in third line, I'll tend to recycle some sort of variation of an oxaliplatin or irinotecan-based regimen, depending on, how much time the patient got on it, how well they did, what are their current side effects, or what are their current issues. So I will recycle some of the old combo more commonly than going to any of these approved third line regimens typically.
We know about Lonsurf. The question is how often do we give it? But yeah.
So there's actually a question, Louise, in the chat of who responded better, FISH positive or HER2 new 2+ or IHC3 positive?
So IHC3 positive had the highest response. There was responses seen. So the cohort A included both of those groups, the 2+ with the ISH positive, and they definitely were responders. But the best indicator of response was the IHC3+. Right. And I think, another important thing to bring up about this is, what these studies are underlying is the importance of next generation sequencing, right, for patients. So, we moved from checking KRAS alone to doing KRAS, NRAS, HRAS, to looking for BRAF and then MSI. And now we're routinely ordering next generation sequencing in these patients. And I think, as I said, there's a signal here for this study. It's going to be a very, very select group of patients, but if we can select them correctly, they could do very well on this regimen. But it's just, it's not ready to go right now, I think.
Yeah, and I will say in my clinic, my entire team knows anyone who shows up with a metastatic GI malignancy is going to be getting next generation sequencing. It's just kind of standard of care in my office now. So, and I don't think that was the case years ago. So I think all of the studies that have come out of ASCO in GI oncology in the last several years, I think lend themselves to a better understanding of why it's so important to send these tests, because they really do impact how we modify our care on these patients.
Yeah, I think ASCO recognized that as the advance of the 2020, right, as the molecular profiling in GI cancers, and I would fully support it as well.
Yeah, I mean, it's an exciting time in GI oncology. I think we're learning so much. I really feel like the amount of that we're learning about GI cancers is a very steep curve right now with what we're able to modify. And while we're still looking for those third and fourth line options, I think that hopefully as we learn more about the molecular makeup, we'll have better options in the next couple of years, theoretically. At least more personalized options, I guess you could say. All right, so moving on to the next abstract. So the next abstract we were going to discuss today is 3507, the TRUSTY study, which I just really like the name of that study, to be honest. So this is a randomized phase 2/3 study of Lonsurf plus bevacizumab versus irinotecan and fluoropyrimidine plus bevacizumab as second-line treatment in patients with metastatic colorectal cancer. So we know that there's been a benefit with Lonsurf plus Bev for metastatic CRC in some trials in the past. So this was a randomized phase 2/3 trial looking at non-inferiority to FOLFIRI or S1 and irinotecan plus Bev as second-line therapy. So the methodology, you need to have failed first-line doublet chemo with either Bev or an anti-EGFR antibody in cases of patients who are RAS wild type. And patients were then randomized to either into the Lonsurf plus Bev or FOLFIRI or S1 and irinotecan plus Bev. And the primary endpoint was overall survival. And they were looking at a non-inferiority margin of hazard ratio of 1.33 based on the assumption of a median survival time of 19 months for the control. The secondary endpoints they looked at, progression-free survival, RR, DCR, TTF, time to post-study treatment failure, and a proportion of patients who were receiving post-study treatment, quality of life, and safety. So they had a whole bunch of secondary endpoints. And so the results I thought were interesting. So the study was actually terminated in July of 2020 because during the interim analysis for futility, what they found was that there was a median overall survival of 14.8 months in the Lonsurf plus Bev's group and 18.1 months in the control group. And so they decided that non-inferiority had not been demonstrated. They found a median progression-free survival of 4.5 months in the Lonsurf plus Bev group and 6 months in the control group. And so they concluded that Lonsurf and Bev did not show non-inferiority to FOLFIRI or S1 and irinotecan plus Bev as a second-line treatment in metastatic colorectal cancer patients. And there was a discussion about what the future directions could be. But before I go into that, I want to hear what Louise has to say about this particular study and what she took away from it.
I'll try to be brief because I feel like we're dominating the discussion with colorectal, but anyway, so, you know, again, I think this is an interesting study, right? We're trying to see what we can change, right? You know, we have FOLFOX first line, FOLFIRI second line, we alternate them. And the question is what we can change in the space in terms of second line. You know, definitely there is data to support the use of this in first and third line. And this, you know, was highlighted by the authors when they presented it. I think some of the argument was that life on irinotecan is tough for patients, and could we improve quality of life for patients by avoiding the irinotecan combination and using Lonsurf instead? Again, I would say in clinical practice, I think a dose-modified irinotecan gives a better quality of life than taking Lonsurf, to be perfectly honest with you. But, you know, this was a negative trial effectively. They didn't show non-inferiority. It was interesting because the control arm included, you know, the two different groups, right? So you had the patients who had 5-FU with irinotecan bevacizumab, and then you had the S1 irinotecan bevacizumab. And there was some discussion around the fact that patients who were intended to use S1 were doing better, right? But then they saw there was an imbalance in terms of the patients who had KRAS wild type tumors. So I don't think this is something that is going to change practice for people. I think it's interesting that they did this study, but I think going forward, I would still prefer to do a dose modified FOLFIRI over Lonsurf in combination with Avastin in patients. That would be my take on it. This was the study, I'll be honest with you, that I found the most underwhelming of all that we've discussed so far. I mean, I think, again, we're trying to find other options for patients. What's more attractive? Lonsurf is oral. It sounds easier. There's a lot of negativity around irinotecan. Most of the patients in our clinic don't experience the alopecia that you see in a lot of other cancer clinics, right? And one of the questions that comes up in a GI clinic, particularly in a colorectal clinic, is, you know, will I have hair loss? Because most of our patients don't, right? They have hair thinning rather than hair loss. And I think in women, it's a big factor. And, you know, I think that's some of the rationale is, can we save patients? That saves them the diarrhea. But again, I think if you dose modify, that again, quality of life is better than on Lonsurf Avastin.
Yeah, I agree with you. And don't worry, everybody, we will be moving to the upper GI soon. Yeah. we still have time. But yeah, I agree with you. I think that, you know, Lonsurf is usually my go-to for the third line, but I just don't see the benefit to putting the patients on a drug that doesn't really have any benefit for survival or progression-free survival. And to be perfectly honest, my patients still have side effects with Lonsurf. It's not that it's a drug that comes without any side effects at all. So when you look at the quality of life versus overall survival, progression-free survival, I don't really see any major benefit. So I agree. I wasn't really excited about this. I mean, I was excited at the concept of this study, because if it had been positive, it would have definitely been a game changer. But the fact that it kind of revealed what I think a lot of us were expecting it to reveal, that Lonsurf isn't superior and likely will not be anybody's first or second line choice when it comes to these patients. So, the future directions that they talked about was a subgroup analysis is ongoing to investigate patients who likely benefit from Lonsurf and Bev. So I do think that will be interesting to see the patients who did benefit from Lonsurf and Bev. Did they have specific things about their particular cases that made them more susceptible to that particular drug? So I'd be interested to see if they find something in that post-hoc analysis, but I'm not holding my breath, to be perfectly honest. So question, are we changing our practices based on this study? It doesn't sound like anyone's planning on moving Lonsurf up in the line of therapy. So it doesn't sound like this is changing practice at this point.
Not for me.
All right, so now we're going to move on to the other half of the GI tract. So next we'll be talking about abstract 4001. So this study looked at Nivo plus IPI or Nivo plus chemo versus chemo as first-line treatment for advanced esophageal squamous cell carcinoma. And these are the first results of the Checkmate 648 study. So background on this study, Nivo we know is superior for overall survival versus chemo in previously treated patients with esophageal squamous cell carcinoma, as we saw in the Attraction 3 trial in the past. So this study looked at overall survival and progression-free survival from Checkmate 648, the first global phase 3 study to look at IO chemo combo and IO combo in these advanced esophageal squamous cancer patients. So the methodology, they looked at previously untreated, unresectable, advanced, recurrent, or metastatic esophageal squamous cell carcinoma patients, and they looked at these patients regardless of PD-L1 status. So the arms, again, were Nivo plus chemo, Nivo plus IPI, or just chemo. And the primary endpoints were overall survival and progression-free survival. They looked at 970 patients. And so what they found was that the Nivo chemo and the Nivo IPI cohorts did have a statistically significantly improved overall survival versus chemo alone in patients with tumor cells that had a PD-L1 expression of greater than 1% and also in all randomized patients. They found that Nivo plus chemo versus chemo had a statistically significant progression-free survival benefit, and that was with a p-value of 0.0023 in patients who had a tumor cell PD-L1 percentage of greater than 1%. They found progression-free survival in Nivo plus chemo versus chemo patients, Nivo plus IPI versus chemo in patients with tumor cells of a PD-L1 of greater than 1% did not meet the pre-specified boundary for significance. They found the objective response rate was 53% for Nivo plus chemo, 35% for Nivo plus IPI, and 20% for chemo patients in patients who had PD-L1 expression of greater than 1%. For all patients, regardless of PD-L1 status, that was 47% for Nivo plus chemo, 28% for Nivo plus IPI, and 27% for just chemo. They found there was a longer median duration of response observed versus chemo for patients who had a tumor cell PD-L1 status greater than 1%. So lots of tongue twisters in there, but the conclusion from this study was that Nivo plus chemo and Nivo plus IPI both demonstrated superior overall survival versus chemo, along with a durable objective response and acceptable safety profile in patients who had advanced esophageal squamous cell carcinoma. And this study concluded that each of these two options, so Nivo plus chemo or Nivo plus IPI, are potential new first-line treatment options for these patients. So let's start with Mike. Mike, give us your thoughts on this particular trial. What did you take away from it? What did you find interesting and what did you find concerning? Anything?
For a couple of global comments, first of all, we're blessed by having many chemo-immuno first-line trials. I think Shikha pointed that out earlier, but we could also refer to 649 or Keynote 590, among others. But what sets this one apart is it's for only squamous cell cancer, as opposed to adenos of, say, the esophagus, GE junction, and stomach. This I had 70% patients from Asia, but I think the reason for that is it's just hard to find patients with squamous cell of the esophagus in the States. Very large study. I would note that 50% of the patients overall randomized to either of the three arms had a CPS greater than 1. So it's about a 50-50 split by CPS score. I think what's excellent about the take-home message is we now have a frontline chemo IO option, which is clearly better than chemo alone in this patient population, which supplements some of the data we've seen in adenocarcinoma of the upper GI tract. I'm puzzled on what to do with the Nivo IPI group. I know that it was compared to chemo, and as you pointed out, it was considered to be better. But it would certainly be nice to have a chemo Nivo versus chemo IPI Nivo or something that would give me a better idea how much the contribution was made by the second immunotherapy versus Nivo. And then finally, one thing I was a little bit surprised about is, although I don't give a lot of dual immunotherapy like my colleagues in melanoma or renal cell, for example, I've always been told that the immunologic related adverse events are much higher for dual immunotherapy than single. But when I went over the related AEs, I don't think I really saw that much of a difference as I expected to see. So for folks out there who would consider using the IPI-NIVO alone in the front line, perhaps it's good to look a little more closely at the toxicity tables. And then another thing that'll come up in our assessment of the esophagus or upper GI chemoimmuno trials is the whole issue of checkpoint CPS score selection. And the overall benefit was shown, but if you look in the forest plots, it would appear to me that the majority of the benefit was obtained from the patients that had a CPS score greater than 1. So the interpretation is that you can use it marker agnostically, but you may be treating some patients that are not getting a benefit. On the other hand, if the toxicity of the Nivo isn't too bad, then they're just essentially getting chemotherapy side effects regardless. And you may pick up a few responders whose CPS is less than 1. But I think this is a practice-changing abstract for patients with squamous cell cancer of the esophagus that's recurrent metastatic in the first-line treatment setting.
Sam, what do you think about all of that?
Yeah, I think I don't have a lot to add to Mike's really nice summary, and I apologize for the siren. It's nature of living in the city. But
I thought that was
first, when I see a trial, I always try to ask myself, is the question relevant? And this is a relevant question. Does immunotherapy, in addition to cytotoxic chemo, improve outcomes? And can we get away without the chemo backbone? And those are both important questions. And then I'd say, does this apply to my clinic, my patient population? And to be honest, we don't see very many squamous cell esophageal cancers, just demographically in Boston, but we do see some. And so I do think this is relevant to my clinical population. And then I start to do exactly what Mike did, dive into the design and dive into the subsets. And this is a Nivo trial, so they do use tumor cell staining, not the more typical combined positive score that we're used to seeing for a lot of our, for the pembrolizumab label. And certainly, we'd love to see CPS done with this data set to enhance the comparability. But the take-home message for me is the same, as Mike said. I think there is enriched activity in biomarker-selected patients, and those are the patients that express or higher levels of the target, and that's PD-1. And there is a clear improvement over chemotherapy. And I would argue that basically any squamous cell cancer patient with advanced disease who's a candidate should be offered an IO containing regimen. And I struggle with the same thing as Mike. I think my preference is going to be 5-FU oxaliplatin and potentially Nivo. I know they use cisplatin in this trial, but I just don't think there's any real need to be using cisplatin. And then which arm is really do you go with? I think I like the response rate being substantially higher in the FOLFOX nivolumab, because that is often associated with clinical improvement in quality of life and ability to swallow. So I was concerned that the response rate of like 53% for FOLFOX Nivo drops down to in the 30s with Ipi Nivo. And there's a little bit change in the shape of the curve. There's a little bit of an earlier drop off for people that have primary progression. So it's hard for me to say that there's going to be a lot of situations where I'm going to favor Ipi Nivo over 5-FU platinum Nivo based on this trial, but they do provide data to suggest that it is superior to chemotherapy. But I suspect that in practice, many people will have comfort with FOLFOX Nivo or potentially this regimen cis-5-FU Nivo. And I suspect that if both were available, that would be the predominant pattern. It will be interesting to see what regulatory bodies do with this data. But overall, I completely agree with Mike. I mean, more tools is great. Squamous cell is clearly a population where like platinum 5-FU and Nivo is the standard.
Getting back to Sam's point of thinking about the patient, I guess you've keyed in my thoughts about why I would use cytotoxic Nivo versus dual immunotherapy, and that's exactly response rate. Squams really respond quickly to 5-FU and platinums, and these patients often come in with malignant dysphagia and real nutritional challenges. So your point is taken. I would favor the chemo immuno approach, and of course I would not use 5-FU cisplatin because that's just not friendly for a patient you're treating for palliative intent.
So the question of what changes Monday morning. So do you think that this is going to change your practice now, or do you think it's something that might change your practice in the future? Is this something that we're ready to make the jump now and start implementing this into practice now, or is it something we still need more data on before we start making that change?
I vote for now.
I think this is ready for prime time. The next advanced squamous patient that comes through my clinic is getting 5-FU platinum and a checkpoint inhibitor, almost certainly.
Great. All right, so moving on to the next abstract. So this abstract actually kind of touches on what Louise and I mentioned earlier, talking about colorectal cancer and immunotherapy in the adjuvant setting. So this is abstract 4003, looking at adjuvant nivolumab in resected esophageal or gastroesophageal junction cancer following neoadjuvant chemoradiotherapy. And this was the expanded efficacy and safety analysis from Checkmate 577. So the background for this study: in Checkmate 577, Nivo demonstrated a significant and clinically meaningful improvement in disease-free survival versus placebo. It was well tolerated in patients with the resected R0 stage 2 or 3 esophageal or gastroesophageal junction cancer who received neoadjuvant chemo-RT and had residual pathologic disease. This study found that the median disease-free survival doubled with Nivo, 22.4 months versus 11 months. So the methods for what they did in this particular report of this study: patients were randomized 2-to-1 to Nivo or placebo for 16 weeks, followed by Nivo or placebo every 4 weeks. And then the data that's presented in this abstract was the additional efficacy, safety, and quality of life data. So the results that they reported: there were 794 patients who were randomized to either Nivo or placebo, 532 in the Nivo group and 262 in the placebo group. And distance recurrence was reported for 29% versus 39%, with local regional recurrence of 12 versus 17% in the Nivo versus the placebo groups, respectively. And the median distant metastatic free survival was 28.3 versus 17.6 months for the Nivo versus placebo group. They found that the median progression-free survival 2, so looking at a later analysis, looking at time from randomization to progression after subsequent systemic therapies, initiation of a second systemic therapy or death, whichever came first, was not reached with Nivo of 32 months. It was not reached with Nivo versus 32 months for the placebo group. And the treatment-related adverse events were with potential immunologic etiology were reported for Nivo, but the results showed similar trends for quality of life, improvement from baseline for Nivo and placebo during treatment. And these differences were maintained and the benefit was maintained in the post-treatment setting. And so this particular study concluded, looking at this particular analysis, they showed that adjuvant Nivo demonstrated clinically meaningful efficacy, an acceptable safety profile, and maintained quality of life, which further supports its utility as standard of care for patients who have resectable disease, who receive neoadjuvant chemo-RT with residual pathologic disease. So basically, the study was looking at adjuvant IO therapy in patients who had neoadjuvant chemo-RT and looked to see if there was a benefit in their quality of life and the efficacy, and kind of whether this is a reasonable treatment option for this particular patient population. So I'm going to start with Sam on this one. Sam, tell me kind of your overall thoughts on this study. Do you think this was an interesting study? Is this something that you thought was a worthwhile study to do? And then what did you take away from these results?
Yeah, I think it's one of the few examples where maybe we got ahead of colon cancer in the adjuvant space. But yes, you know, adjuvant IO has demonstrated activity across a couple tumor types, and this is now, I think, the third one to show an improvement in outcomes. A couple high-level comments. One, it's a stark reminder of how poorly these patients do. You know, we give patients trimodality therapy, which is a lot to go through, and then in the cross trial in the adenocarcinomas, the PCR rate is only 23%. So that means 3/4 of patients will be left with residual disease after going through chemoradiation and a big operation. And if you look at the control arm, it gives you a sense of, you know, how high risk that is. The median DFS was under a year. So a lot of people are recurring quickly, and it's a reminder that we just need to do better. And one of the places to look better, because it's really hard to give adjuvant chemotherapy after an esophagectomy, is IO. And this was a great study design, very practical trial, very good question. And when it was first presented at ESMO in September, I think immediately was practice changing. And I think people were scrambling to try to offer this to their patients who fit this criteria pretty much immediately. And I think the regulatory bodies recognize that and approve the drug based on the activity, which is now published. A few kind of more granular comments. The DFS, even with adjuvant Nivo, is still under 2 years. So there's definitely more room to build. And maybe that means we need to be better at giving upfront therapies prior to surgery, or selecting patients, or using MRD, et cetera, as Louise mentioned in colon. And then I think it's clues to some biologic groups. You know, again, consistent with what Mike said, we do see the magnitude of benefit higher in the biomarker selected group. And here they showed CPS scoring and as well as tumor cell scoring. And both of those criteria allowed you to identify patients who are more likely to benefit. Histology matters. Squames do seem to have a greater benefit than adenocarcinomas, but everybody's benefiting here. And then finally, it's, as someone who's interested in the GE junction and some of the biology there, you know, the GE junction adenocarcinoma is a tough group. And if you look at the hazard ratio for that population, I'm going to double check myself now, but yeah, it's 0.87. So these are not the patients who look to be deriving a lot of benefit. And that's, you know, that's 330 patients. So it's a targeted group where maybe we can further focus on optimizing, but this is a pretty well tolerated. Most patients, you know, there was no clear difference in quality of life between doing nothing, placebo, and doing this agent. So I think the toxicity we all know for nivolumab, it's real and it's there, but we have experience. And I think this was very validating for the data that was already presented, and many of us were probably already doing this. and would continue to do this. I think the PCR group, the patients that do have path responses, they still recur too, they just do it less frequently and it takes longer. So there may even be opportunities to consider expanding this ultimately to everybody, but we don't have that data.
So what do you think, Mike?
Well, first of all, thank you, Sam, for that fantastic summary. I think you pointed out that the secret was leaked at ESMO, and the answer to is this practice changing has already been determined. I think, as you would say, a few less granular points are that 30% of the patients had squamous, and they treated all comers agnostic of marker expression. And when I talked to Ronan, also from Ireland, by the way, Louise, the PI of this, I asked him, didn't you think you were diluting it out to the point where you were shooting yourself in the foot by not selecting patients, by using all histologies and so on and so forth? He said, well, the one thing I didn't do was include the path complete responders. I said, okay. But despite all of that, this is really incredible data, and we were all scrambling to use it because it's really just so great. I mean, as Sam mentioned, it's very hard to squeeze in cytotoxic therapy in patients who have had chemo-RT followed by surgery. We've tried it, and there's at least a 50% drop-off rate. What's notable about using nivolumab is not only does it work, but number two, they presented their quality of life data, and there was no difference in quality of life between the nivo and the placebo patients. So we have a real winner here. It works, but it doesn't hurt our patient, with the exception of the rare IR related adverse events. But yeah, this is a really nice study.
So it sounds like this study might actually cause some changes Monday morning for people who weren't actually already doing this, incorporating this into their regimen. So Mike and Sam, do you guys agree that this is pretty exciting data and potentially practice changing for people who hadn't already incorporated this into their standard of practice?
Yeah, I think if you're taking care of these patients, you need to be aware of this data, and it needs to be a consideration for essentially everyone who would fit this bill, which is a lot of patients. Chemoradiation is still the most common standard in the US, and most of the patients will have some degree of residual disease. So this to me is one of the easier, more straightforward yeses in terms of practice changing.
Yeah, the next step is to come up with something to help I think it's about 30% of recurrences that happen in the path CR patients, but I'm sure someone sharp is already working on that.
Excellent. So any other comments on this trial or on this abstract before we move on to the next one? Excellent. So I think regardless of the results of the next abstract, it's my favorite name of an abstract, the NIFTY study. I'm a huge nerd when it comes to coming up with names for trials and studies, and I'm very bad at it. So I'm always really impressed when people are able to come up with really great
What's the best one you've ever created?
Oh, I am bad at creating them. So I ask other people to create the names for me. We actually just did a study looking at COVID-19 and misinformation, and that one was called the PEACE study, PEACE, which if you ask me what it stands for, I cannot remember off the top of my head, but it has something to do with misinformation. So.
Great.
All right, so this NIFTY study, which like I said, I very much like, it's abstract 4006, and it looks at liposomal irinotecan in combination with 5-FU and leucovorin for patients with metastatic biliary tract cancer after progression on gemcitabine plus cisplatin. This is a multi-center comparative randomized phase 2b study. And I will say I was excited to see the results of this because, as we all know, biliary tract cancers are a beast to treat and are really a challenge when it comes to finding systemic therapies that work. So the background of this study, we know there's really no globally established second-line therapy that can be utilized effectively for these patients who are on GemCis. The ABC06 trial showed there was some clinical benefit of FOLFOX compared to symptom control, but more investigation is needed in that realm. So the methods of this trial, this was an investigator-initiated, multi-center, open-label, randomized phase 2b study. And patients had to have a good ECOG performance status 0 to 1, and they had to have histologically confirmed metastatic biliary tract cancer and disease progression after first-line GemCis. So they GemCis or sorafenib, and they found that tumor downstaging occurred in 16 patients, 12.3% of patients, including 15 patients who received curative surgery or ablation. They found a median overall survival of 20.8 months with a 1-year rate of 93.8%. And they were doing an analysis of predictive biomarkers based on the whole genome sequencing were still ongoing at the time that this abstract was reported. So what this study concluded was that, nope, hold on. Let me make sure that I didn't just skip a page. Sorry, give me 1 second. I think I got my pages confused. So let me make sure that I'm saying this correctly because I don't want to mess this study up. All right, so the liposomal, the 406, GemCis were eligible. Okay, here we go. I am so sorry. This is what happens when you have papers as opposed to things on your computer.
Old-fashioned.
I know this is, I'm not used to having things printed out anymore. It's become my computer has become a crutch. All right, let me make sure that I'm looking at the right study.
And if you want, I have some notes I can go over on your behalf.
Yes, that would be lovely because I don't know. I think my papers got out of order. So if you could share your notes, that would be great. And apologies.
I also like the nifty acronym.
I know. After I said how much I love the acronym, I then messed up my overview of the study.
Well, you know, you distracted yourself.
I did.
This is a study done in Korea for a very rare, but also very bad, Shikha pointed out, disease. And it was trying to define whether there is sort of a new standard of care, second line regimen for these patients who have gotten, most of them I think got GemCis as their frontline therapy. There are some other trials that suggest giving 5-FU or FOLFOX-based regimens. I think one of them was the ABC study that you reported, but the other one, translating from pancreas, was the Napoli-2 trial, which used a 5-FU set of drugs after, I think, Gem or Gemabraxine. But anyway, it's a 2-arm study of 178 patients, a relatively small but a rare tumor type. And the randomization was to 5-FU leucovorin, which is going to be considered sort of the default second-line standard, versus this thing they call Naliri, I believe, which is not nanoliposomal irinotecan, which I think is an nth-line study for pancreas as well, with an outcome of survival. And what I have is their hazard ratio here for overall survival is 0.68. So it's a 32% reduction in the risk of death with the liposomal irinotecan versus 5-FU leucovorin. Not treating this disease, one question I would have is why did they not use something like FOLFOX as their control arm, which potentially, at least in the States, would be considered standard, with 5-FU alone being substandard. But just on face value, the study I thought was well done, and they did answer a question with level 1 evidence, which is that liposomal irinotecan is a choice in the second line for this disease.
Thank you, Mike, for taking that over. I definitely had my pages out of order. So, so Sam, I'd love to hear what your thoughts are. Again, this is a very difficult to treat disease. And for anyone, you know, I've treated many patients with this type of cancer, and we don't really see a lot of benefit from a lot of different types of systemic therapies. So I'm curious as to what you thought about these results and how you would utilize them in your practice, if in any way at all.
Yeah, I think it's, you know, it's a tumor type that I think is evolving quickly, which is great, mainly because of the increased molecular understanding of some of the subgroups. You know, we see FGFR2 fusions, IDH1 mutations, other less common features, HER2, BRAF, MSI, etc. So I think to Louise's point earlier on, you know, underlies the need to genotype these patients, and probably next-gen sequencing is the preferred approach. My comments on the timing, I think it was probably a timing issue of the design in terms of why the comparator arm wasn't FOLFOX. That data is, you know, published not that long ago in the second line.
Got it.
And 5FU is a reasonable control. And so they were asking, instead of FOLFOX, can we use a version of FOLFIRI, in this case, Nuliri? And it looks like there's activity there. Yes, I agree, the modern control probably would be FOLFOX here. And who knows if the results would hold up between those two comparisons, but it's, I mean, the activity of chemotherapy in the later lines of this disease is underwhelming, period. And I don't think it matters. Yeah. I think, you know, where we're seeing more progress is in the front line, you know, the cisgem Abraxane and some of the aggressive combinations, maybe driving more of an improvement than some of these second line therapies, which they do help some people, but certainly it's not a large proportion when you see the shape of those curves. I don't treat a lot of this disease, so I'm sure there's people who could contextualize this a little better, but I would suspect that it puts another option potentially in your pocket, but I'm not sure how frequent this will be in the US. I suspect, you know, for patients who are not candidates for any molecularly targeted agents, I would have my guesses that FOLFOX may remain, but it's nice to see more data that's supportive of something better than 5FU.
And I did notice, just to augment your point about NGS, I'm pretty sure I saw this in the presentation. 20% of the patients had an FGF receptor, I guess I'll call it abnormality. I'm not sure what the test was, overexpression or point mutation, but those were included in this cytotoxic therapy trial.
And I think it's important to note, so the investigators concluded that the Nuliri plus 5FU leucovorin significantly improved both progression-free survival and overall survival compared to the 5FU leucovorin. And so patients who'd progressed on this GEM-CIS, as you mentioned. And so they're talking about it as should be considered as second-line therapy as standard for advanced biliary tract carcinoma. Do you guys think with this data that that's something that you would potentially incorporate into your standard of care as second line for these patients with this data from this study?
I would say I'm, as with Sam, I don't treat this very often, but I do go into tumor boards. So I think most people here would reach for FOLFOX. It could just be that we don't have the nanoliposomal irinotecan yet available here, and it may just be preferential to use FOLFOX due to convenience and you know, ease of attaining.
Yeah, I think you know, bilirubin elevations are not uncommon in this population, and certainly a factor with irinotecan and all variants of. And I won't say much. I agree with Mike. I think, you know, if this were available, I think there's subsets of patients that people would use it in the second line immediately. It's a phase 2 trial. It's not a very large trial, and I'd have to look into the details of their ability to look at the overall survival. But if it were available, I suspect it would get used in a subset of patients. It's all Asian data, so it's a little hard to generalize. You know, common criticism of an population entirely of one geographic area.
Can I ask a little bit of an off-point question? I treat some patients with this, not that many, but so, you know, GEM-CIS obviously is first line. In terms of choosing the second line, sounds like I always do the same thing I do in colorectal. I actually tend to go towards FOLFIRI rather than FOLFOX. But what is your classification that, you know, they're still like platinum sensitive, right? Do you use a 3-month, a 6-month, like when they recur or progress, in terms of if your choice is to go from GEM-CIS to FOLFOX, for example?
Good question that I can't answer. Perhaps Sam.
Yeah, I think it's a great point, and I can't remember exactly what the ABCO6 trial did to define platinum sensitivity, but I would certainly take a look at that and probably use the same criteria.
Mhm.
Okay, in the last 7 minutes, I'm going to try to give a brief overview, very brief overview of this last abstract we were going to discuss. The abstract is 4007, and I've got my papers in order now, so I should be able to give you a quick overview of it. So this was a study, the FOHAKE-1 study, hepatic arterial infusion chemotherapy of oxaliplatin plus fluorouracil versus sorafenib in advanced hepatocellular carcinoma, a biomolecular exploratory randomized phase 3 trial. So I'm going to very briefly discuss this study. The methodology for this study, it's an open label phase 3 trial, and patients were assigned 1-to-1 to either undergo hepatic arterial infusion chemo of FOLFOX or sorafenib therapy. And patients who were in the hepatic arterial infusion chemo group, they were recommended to receive tumor and normal tissue biopsy to search for potential genomic biomarkers to predict response to treatment. So there were 551 patients recruited, 260 eligible patients were randomly assigned to receive this hepatic arterial infusional therapy versus sorafenib, 130 in one group, 132 in the other. And they looked at patients who had macrovascular invasion with or without extrahepatic Mets. 82.8% of patients were in that subgroup. The median tumor diameter was about 11.7 centimeters, and the percentage of patients with greater than 50% tumor volume involvement in the liver was 41.5% and 39.4% respectively. I thought that was really interesting because it's a pretty significant amount of tumor burden that these patients had. At the time of the data cutoff, there were, which was October 31st, 2020, there were 190 deaths, 79 in the infusion group and 111 in the sorafenib group. And patients receiving the infusional fluorouracil therapy had a median overall survival of 13.9 months compared to 8.2 months for those receiving sorafenib. Tumor downstaging occurred in 16 patients who are getting the infusional therapy, including 15 who received curative surgery or ablation, and finally achieving a median overall survival of 20.8 months with a 1-year survival rate of 93.8%. So this randomized phase 3 trial proved in their conclusions that the infusional therapy had a superior efficacy and survival outcome when compared to sorafenib in the first-line treatment of primary diagnostic advanced HCC, indicating that patients who had heavy intrahepatic tumor burden, this particular type of infusional therapy may be a better strategy than sorafenib. So I have some thoughts on this study, but I'm curious, in the last 4 minutes, Mike and Sam, do you have any thoughts on how this study was carried out and what the implications are of this?
I can start if you want, Mike.
Yeah, appreciate it.
Yeah, I honestly had a little bit of trouble placing this in terms of what to do with it at a practice-changing level. I mean, I think it's a clean design, it's good data, the combination is active, and there's some really nice responses. Mm-hmm. It's a technology and approach that, you know, Louise probably knows much more than me about because she practices at a center that really pioneered some of these hepatic intra-arterial therapies. It's not going to be available to most patients, and really it does require a lot of expertise. And then, of course, the biggest problem is that even if you had this technology, sorafenib is no longer the control arm. We have atezo and bev, which is very active and very encouraging, and you know, trial to trial, hard to make the comparison, but I suspect that this data would not look quite so impressive against that as a comparator. And I think those are my main, I'd say, comments. Is I'm interested in this approach. I think they were very cool to get biopsies and look at genomic predictors of response, and it's a really cool data set that they can do some interesting things with, and I kudos to them for thinking and doing that. And then examining hepatic arterial infusion in a large cohort is cool. Like, it's an interesting approach. And I think, you know, some of the data that I've seen come out of Memorial for other tumor types, it looks really good. And so I think maybe there's something to it, but it's hard to say you can act on this trial.
I just think the only thing I can add is this must have been a tremendous amount of work to do this study in 262 patients. And I'm afraid they were caught by the timing, as I think we had when we talked about another study, that the systemic therapy that they used here is history. So I think we have to leave this to folks like Louise and her colleagues to try to figure out how we can fit this in. Of course, yours is with liver mets and colorectal cancer, but I imagine the approach is similar.
Well, my only other comment, Shikha, is I'm going to rename this the FOHAWK study, which is like I don't quite have it, but I'm just trying to get a good name for you.
I like
I'm gonna
that
just put in
name.
my tuppence worth about hepatic arterial infusion very quickly. So clearly I'm a big advocate of it. It's the majority of my practice here. I think, the evidence that we have from here is not in HCC per se, it's in colorectal liver metastasis that was mentioned, and also in cholangiocarcinoma. Some of the earlier studies here did incorporate, some HCC patients with cholangiocarcinoma, and we definitely weren't seeing responses. The other thing I would say from the general community is the criticism of not having randomized studies with HAI. So again, I echo the the praise for this group in terms of doing it. I don't think this is something that is going to change practice here in the US currently. And as I said, we're not using it in HCC right now. And also we use different agents through the pump. So we use a prodrug of 5-FU, floxuridine rather than fluorouracil, and we're not giving oxaliplatin. But it is used in cholangiocarcinoma routinely, but not HCC here.
Yeah, I want to echo what everyone else said. I thought it was really interesting that they used sorafenib as a comparator, as a control arm, because really I barely use sorafenib in my HCC patients with all the other options that are out there. So, so we are just at 6:30. I want to leave with, if anybody has any final thoughts, is there anything that you want people to take home from this particular Q&A panel? Anything that you think is really remarkable that if people could only listen to the last few minutes of this session, what do you think is something they should take home? So Louise, I'm going to start with you. Do you have any last minute pearls that people should remember from this particular Q&A discussion?
Right. I mean, I think it's just highlighting, how the field is moving in terms of personalizing treatment with molecular testing, and also the focus on immunotherapy options. And I think a big trend that we've discussed through all of this is not just looking at the statistics, but also the quality of life for patients on these newer regimens that are coming out.
Great. Sam, what about you? Any final thoughts?
Yeah, I would say adjuvant PD-1 is here in patients with trimodality treated gastroesophageal and esophageal patients. And then immunotherapy is, in the front line. And I think it behooves us to be somewhat thoughtful about the way we do it, but it may be relevant to a large portion of our patients, squams and adenos.
Great. Mike?
Yeah, I'd just say that for upper GI cancers, meaning esophagogastric, it's easy to become a bit negative and cynical, but based on a number of trials that have been presented recently, there's a lot of hope, and I think it's going to get better.
Excellent. Well, my final thought is that GI oncology is a very exciting space to be practicing and doing research in these days. And I'm honored to be on a panel with such phenomenal people from across the country. So thank you to all three of you for your expertise and your insight, and for sharing this last hour and a half with us and with your expertise. So thank you for that. And to everyone who is attending, I hope you learned something. And thank you so much for joining us. And there's a lot more conferencing and lectures coming up post ASCO with highlights and other information. So please check out the website and see if you can find any other conferences or webinars that might perk your interest. Thank you so much, everyone, for joining us. And we'll see you next time on another What Changes Monday Morning. Thanks.
Thank you.
Thanks, everybody.